Good morning, Loganites. So, I have not actually been keeping up with my nurse practitioner updates. It's gotten to be a lot. I'm going to be quite honest with you. It's gotten away from me. So, last one I had was week 20. We're probably around week 24, week 25 right now. So, what I'm just going to do from this point forward is I'm just going to do an update every time that something happens. It's going to be roughly every week. If things get ahead or away from me, I'm going to still keep updating you. I'm not going to stop, but it might not be every week. And that's okay. It happens. It's a lot. School this semester has really become something. But there is something that's interesting that's happened this week. I got to go to my very first ever conference as an advanced practitioner student, I guess. What I went to is the third annual opioid contest, or not contest, it's not a contest, conference with UT Health Science Center. And there's a lot of interesting stuff that I think that people just need to be aware of. Because I've been in healthcare for 9 years, and I didn't know all of this stuff. I didn't understand some, simple things to remember, just simple facts and figures. So, I'm just going to go through how it happened for me. So, I signed up for this thing because I got an email, and it was free, and I was like, well, I should go to a conference. I need to do more stuff that furthers my education and to get exposure to what other advanced practice nurses are doing, even though I'm not doing it yet. Just to see what the standard is and see what's out there. And I'm really glad I did. So I signed up, I went there. It was raining. It was raining so bad. Almost didn't go, but I'm glad I did. So the first person that came up, now this is all state of Tennessee stuff, okay? And I say that because the two main people that were there were from the state of Tennessee. They were not legislators, but they were on the board of opioid stuff. I don't really know what to call it. I'm sure they have actual positions because they wrote the book for opioid recommendations of the Tennessee for advanced practice nurses. I don't know their actual titles, but that's okay because they did an amazing presentation. The first person that came up was a Dr. Stephen Lloyd, MD. He came up, and this is a unique fellow because he's 20 years in remission of an opioid addiction. And he came up and he basically laid down the law about what it's actually like to have an opioid addiction. And he spoke from a very personable, very real level, and that's the kind of level I like to speak to my patients. So I really appreciate it. And I felt like for the first time of this whole program, I was soaking in knowledge left and right. All right. So the new model for addiction, because there's addiction and dependency, two different things. The model for addiction starts with the risk factor of a 3-tier thing, or 3-spoked wheel. You got genetics, which is your risk, your genetic risk. You got trauma, previous trauma, and you got opportunity. What is the opportunity or the social situation that you're into to be able to be exposed to an opioid? Now, they define addiction different than dependence. Addiction is going to be your continued use of a substance despite negative outcomes. So it's like if you're smoking a cigarette, smoking, and you notice that you can't run as fast as you used to, and you continue to smoke the cigarettes, and then now you've noticed there is a bad outcome associated with what you're doing, and you continue to do it. That is an addiction, okay? Same thing with any other substance. Dependence is going to be different in the fact that if you stop using a substance, whatever the substance is, there is a classifiable and objectively able to be seen physiological reaction to the cessation or the stopped usage of that substance. So, I guess you could technically say, I am dependent on food, because if I stop eating food, well, then there will be a physiological reaction. Whatever the substance is, that's how you know there's true dependency. It's that key qualifier. Fun facts that I didn't know: meth is not something you can be dependent on. You can be addicted to it, not dependent. Alcohol, benzos, and opiates are all things you can actually have dependency. Now, let's talk about the first leg of this biosocial trauma wheel. Biologically, you're going to talk about the family. So, let's say I'm a practitioner or I'm a nurse, but basically, if you're writing the prescription, you owe it to that patient to be able to talk to them and tell them the true risks, because opioids are very risky. for multiple reasons. We're going to get into it, but you owe it to that patient to be able to have that education and one-on-one, so they can have that true informed consent about what they're about to take. The way you are going to ask about the risk factor of, do they have this addiction tendency, you can't ask someone, hey, are you going to be prone to be addicted to opioids? Ever had a drinking problem? Ever had any kind of problem like that? Most people aren't going to tell them themselves. However, we will tell on our family. I know you can hear a train. Hold on, I'm going to let it go. I do want to say this was a great experience, and if you're out there thinking about going to a conference, this was free to me. If it's free to you, definitely do it. If it costs money, I would probably still do it, because I definitely rub shoulders with a lot of people that are in high up positions, and I was made aware of things I didn't know about. Anyways, let's keep going with the family thing. You ask them about their family. Does your brother, your sister, your mom, do you have a family history where people became addicted to substances, alcohol, or illicit substances, drugs, anything like that? People will tell in their family, but what you're really finding out is that they themselves have that biological, the way he called it was like a casino slot machine. The first one, ting, 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 hit. Okay, so it hit the jackpot on the first one. Trauma, the second leg of this. So we're hitting that turnstile for the second one. Do they have previous trauma? And really, what I got out of this whole seminar is adverse childhood events. Because the fun thing about opioids is that it doesn't just get rid of physical pain, it gets rid of emotional pain too. So that aha moment, that euphoric moment, may not just because they're getting rid of physical pain, it can be emotional too. So if you have that underlying emotional pain that you haven't really fixed or gone to counseling for or worked out or coped with too well, this will alleviate that pain. So if you have that pain underlying, you're even at a more risk factor. So pull that thing down, ding. You got an adverse childhood event. That's the second predisposition to it. Now, the way he wanted you to ask about this in a way that actually makes sense in practice is, hey, tell me about your home growing up. What was it like growing up in your house? And, they'll tell you about that. Did anything happen that you now know wasn't supposed to happen? Did anything happen back then that you now know wasn't supposed to happen? And that's a really cool way of asking that question, because that kind of digs to the meat of what we're trying to get. How you ask the questions matter. And that's a cool one that's going to stick with me. Now let's go to the third one, the social. What is socially acceptable? Basically, he more talked about the opportunity. So, are you going to ever be exposed to opioids? Did you have a dental procedure and get exposed to some sort of opioid? What is your exposure? What is available? That is kind of what he wrapped into it. So, like, the case study he used was a young woman that had a dental issue, and they sent her home with like 90 days of pain meds. You don't need that. That's too much. Or 90 pills. Maybe not 90 days, but 90 pills. So like 3 times a day. Whatever it is. They sent her home with a lot of pills. And she liked how they felt. So that was her social, her opportunity. That's where it was. And then he threw out this question. He said, what is the standard dose of pain meds that you send someone home for a dental procedure? What about a long bone fracture? Where do you go look up a standard dose for an opioid? He's like, I don't know of anywhere you can, because no one wants to put a number to it. So he goes, I would like to call that a swag. That's what we call using the swag method. What did he say? A scientific wild ass guess. Oh, that was really interesting. He also goes on to say that opioids relieve the emotional and the physical pain, and also give euphoria. But 10 milligrams, or not 10 milligrams, extra strength Tylenol and extra strength ibuprofen combined gives the same amount of physical pain relief of 10 milligrams of morphine. I can honestly say I kind of believe that, because I've been doing some strength training, and there's days that I hurt, and I hurt so bad. I hurt so bad, and I do mix the Tylenol and ibuprofen together. And I know you shouldn't, because you want the swelling, but like, I'm telling you what, those two things together help me sleep on those days that like really overdo it. I'm not gonna lie. So I get that. So let's say you're in a clinic and you're gonna be prescribing opioids. it is dangerous. You have to do the risk factors, but that doesn't mean you don't prescribe it, because if someone's in acute pain, you got to address that acute pain, right? But when does it start becoming more dangerous? Because, what is the acceptable limit of risk? 3 days. 3 days is when dependence starts becoming a factor in opioids. He said the point that I can get anyone on here dependent on opioids with a 12-day prescription of, I think it's like hydrocodone 3 times a day. He's like, every single person in this room would be dependent on opioids at that point. But dependency does start kicking in about 3 days. That's wild. The second statistic he wanted you to know is that if you write a second prescription, so let's say someone's got acute pain for like a dental abscess, okay, and you write a 3-day prescription of hydrocodones. If they come back for a second prescription of opioids and you write it, there's a 65% chance of them being still on opioids in 1 year. I said that weird, but that's what it is. 1 year later, there's a 65% chance they're still on opioids. Baller. Wild. Okay? And then he also, he again starred that opioids relieves the physical and emotional pain, so you have to be careful with that. Alright. There's 2 parts in our brain, and he dumbed it down. He basically said there's a go and a stop side of your brain. A go and a stop. A go and a stop. The go side of the brain is the oxytocin. It's responsible for survival. It's the limbic system. The stop side is your insight, empathy, and judgment. Okay? And your stop side is your frontal brain. Your go is your limbic, kind of lizard brain, core center. Eating releases the dopamine just like the opioids. So if you can imagine when you get really, really hungry, that times 10 is what he described as a craving for an opioid. So it's not necessarily I want it, okay? You don't want it at this point. It's a craving when you're dependent to that opioid. Interesting point as well. He said that when your brain's developing, issues with opioids is that it kind of disconnects that stop and go side, all right? And what it does is it puts your limbic system, your go side, into the driver's seat. So you only are going for the cravings. There is not much, or if any, insight, empathy, and judgment from the stop side of, should I do this? Is this a good thing for me? It just doesn't, it gets dampened, it gets tampered down. Interesting that females until they're 23 doesn't work like opioids, like their brain doesn't actually connect, and 25 for males. So that same kind of issue where the limbic system, the go side's taking over, you have that issue not as severe, but still there with males and females until 25 and 23 respectively. Which I thought was interesting, because you see teenagers, you're like, why did you do this? They didn't think about it. They didn't think about it because the brain hasn't fully developed. So I thought that was interesting, because the legal age for drinking is 21, but should anyone really be drinking before 25? I don't know. I don't think I should have, to be quite honest, looking back. So it's just interesting. All right. Also, things when we're talking about the brain. He showed us PET scans of people in recovery. So he had a PET scan at never been opioid exposed, currently taking opioids, are currently addicted and dependent to opioids, 10 days post, 100 days post, and then 2 years post. What he showed was a PET scan with no opioids, all lit up, okay? We've got plenty of brain activity. When you go to someone that has an opioid dependency addiction, their brain is, I guess I should say, 0 days dependent, because they're not currently taking the opioids, but it hasn't been any length of time that they have stopped. So no opioids in the system. The brain is very dark. There's not much activity. 10 days post opioid, what do you think? You think, man, there should be more activity because we're off the opioids. It's been some time. No. Because of how the opioids work, your body gets tolerant to it. So either it starts making less of its own dopamine, it reduces the amount of receptors that are exposed on the cells, so that when you get exposed to opioids, you don't have such a big reaction like you did the hundreds of times you did before. So 10 days post, it takes a long time for that body, for those cells to normalize to what you should be exposed to. So basically, 10 days post, there isn't a lot of brain activity on those receptors, so you're not as happy. You don't feel right. I don't know if I'm explaining this right, but basically, 10 days post, you're not where you should be. Okay, I'm like, okay, so 10 days, you're still not going to be where you need to be. What about 100 days post? 100 days post, your brain still is nowhere near lit up as it should be. And I don't know if you want to say GABA receptors, dopamine, oxytocin, whatever you want to say, all those pleasure sensors of the brain still aren't being activated enough because of all the adaptations your brain had to do to survive the mass exposure from the opioids. It takes 2 years. That was the end of this thing. The star takeaway from this point of the PET scans is it takes 2 years for your brain to get back to normalized function. So when you start thinking about recovery, it's not days, weeks, or weeks, months. It's more months, years. Because you're talking, you gotta help this person get through the bad times, and the bad times aren't just the immediate. This is just now, but it's also months from now. So 2 years it takes for your brain to get back to where it should be. That's wild. All right. Theories on why chronic trauma and adverse childhood events are such a big deal in addiction. Chronic trauma lowers the dopamine because the stress hormone cortisol is released, and you have high levels of cortisol all the time because of the stress. It eats away the dopamine. So you've got this low level of dopamine. Your brain's kind of like half functioning, not as pleased as it should be. You get this rush of dopamine when you take an opioid for the first time, and you finally feel normal, or you feel energized. The people that take opioids and feel energized, that's the ones you need to bling, 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 star. Something's not, it predisposes them to being addicted to this because they are lacking that dopamine. And there's some things that you need to do to fix that. And it's not just medication, it's also therapy. All right, addictive personality. This is what I thought was interesting. Addictive personality is not a risk factor for addiction. Now, I mentioned this to my wife, and she said basically she feels that by saying I have an addictive personality is just a different way of saying I have addictive genes in my body. And I kind of agree with her, to be quite honest with you, because how can you sit there and say I have a genetic disposition to addiction without saying I have an addictive personality? The doctor, I think, was trying to make the point that your personality doesn't change. You don't get to choose, like you kind of choose, I don't know if you get to choose your personality, but basically it's not your fault if you're genetically predisposed to being addicted to opioids. It was interesting. And that was our Dr. Lloyd, man. Dr. Lloyd was awesome. Dr. Lloyd, he said that he basically was a resident at the time. He was working 100 hours a week because they didn't have any residency limits. And he was driving home one day and he had some extra opioids in his glove compartment. It was like 15 minutes home. And so he's working 100 hours a week. He's got kids at the house, and the kids are always annoying him. They're always loud. He's working all the time, not getting enough sleep. He's under a lot of stress, okay? He's not under any physical pain, but he's under emotional stress, and he's got adverse childhood events. He was molested by his uncle. He was beat by his parents. So, the first time he took a half of I think it's a Norvico, I don't know. It was an old opiate, okay? Opioid. I keep saying opioid. And by the time he got home, in those 15 minutes to drive home, he said his wife was better, his kids were better, his job was better, and he goes, what changed? He goes, nothing. Opioids relieve emotional pain, but they don't do it forever. You have to keep increasing the dose. You become dependent, physically dependent, and addicted to it. It's a very dangerous cycle. He said, I was teaching, he didn't say where, but he said he was teaching at a college. He was teaching for 4 years at a college while he was using opioids. Okay, so there's 4 years he was teaching, he was using opioids. He said 6 months before he went to rehab, he got given a huge award for being one of the best teachers for teaching a subject. Well, then the week before he went into rehab, okay, the 4 years that the students that he was taking care of were graduating, voted him the best instructor of that school. So the graduating class that was with him for the 4 years of his drug use, he was given the award for the best instructor. And he said, during that award ceremony, I went into the bathroom and I used 160 milligrams of Oxycontin. You think you can tell what a drug addict looks like. I'm here to tell you, you cannot. And the only difference between me and those people that were sitting on the side or living under the bridge is education and opportunity. Because there wasn't much difference. So, I thought that was interesting. And then an interesting person that came up named Jennifer Anderson, MD. She came up for screening of substance abuse with pregnancy. So a lot of the times that people are using substances like opioids in the field, they come to get treatment for getting out of that cycle when they become pregnant. They're like, oh, I've got to change something out of a baby. But what you have to realize, they've already been exposed to opioids. So how do you do that? So you have to ask them if there's any history of substance or alcohol use of parents, peers, partner, past pregnancy. Goal of this, and I thought this was interesting when you get this kind of patient, and of course you have to be educated and ready to be and feel comfortable to treat a opioid addicted person or an opioid user. I don't know how you want to say that nicely. Your goal is to actually quell the cravings, not the lowest dose needed, but to quell the cravings. So, like with methadone, the question was, what's the goal? It's to quell the cravings. What I thought was interesting, you don't want the lowest dose because you don't want them to go back to it. You don't want them to double up. And interesting, since these babies are already opioid exposed, there is no maternal dose correlation to neonatal abstinence syndrome or withdrawal syndrome. Interesting. One of the drugs that they use is buprenorphine. Hope I said that right. Please don't gouge me. It's absorbed by the mucosa. So you can treat someone who's breastfeeding with that, and because it gets eliminated like 97% through first pass effect, unless the baby sits there and holds milk under its tongue, it's not going to get any. So you can actively be treated for an opioid addiction or dependency, however you want to look at it, depending on what stage of recovery you are, with this drug and still breastfeed your child. And it's very interesting because the Dr. Lloyd was talking about how there was a nurse or a psychologist or something that basically said got onto a mom about breastfeeding their kid or their child when they were on this because, yeah, he just wants another fix. That's why you're having such a good time breastfeeding. That's just not good, man. That is not good at all. So, I just say that to, I know it's easy to be like, oh, they're drug-seeking behavior, yada, yada, yada. But, like, even if they are drug-seeking, you can't make them stop cold turkey. Can you take away someone's food? Like, you got to give them help. I just thought that was interesting, and not to put them down either. All right, fun facts about your early brain development. So during your childhood years, your brain overproduces synapses between 0 and 2 years old. So in your first 2 years of development, your brain overproduces brain synapses and brain material. The pruning of that brain material happens between 4 and 6. So you have overdevelopment of all of this brain material, and then you prune it down between 4 to 6 of the stuff you want to keep, stuff you don't want to keep gets cut out then. So the adverse childhood events are those that happen between that time, because either you're not going to grow enough or you're going to prune out the wrong stuff. That's why that window is so key, because so much brain development happens during that time. Basically, the abuse, neglect, or household dysfunction are your three things that are going to affect that brain development. Abuse is pretty straightforward. Emotional and physical abuse count. Emotional can sometimes be worse. Neglect, obviously not taking care of them. And something that was brought up that I thought was interesting is like how you hear parents let the baby soothe themselves when they're crying. That's not good. And that's not good because of one thing, of a main thing. When a baby starts crying, they're crying for help, right? They want help. That cycle of if they're crying for help and you don't give it to them, well, then they don't live in a safe environment, or that's how they feel, right? And that's a big deal because they have to have that feeling of safety to move on to more brain development. Growing up, I grew up here in the South where men didn't become nurses. You didn't give in to a baby, but it's important when that baby's crying to give them the help that they're asking for. I didn't ever look at it that way, and I thought that was very interesting because if you don't give them that help, it's not a safe environment to the baby. It's the wrong kind of feedback you want to give them. So your baby's crying, give them the right kind of feedback and be supportive for them. And then household dysfunction. And basically the other household dysfunction with the adverse childhood events is basically talking about drinking, smoking. Does the one parent hit the other parent? Is there a good relationship? Is it supportive to the children? Do the parents have a good relationship? That kind of thing. So, and that's, everyone's heard about adverse childhood events, I'm pretty sure at this point. An interesting fact that he did say that why it's so important to have that good relationship between parents and between the child is stress can be tolerable or toxic depending on relationships. I thought that was interesting because if you even think about like working in the ER, think about a day that you've got a good team and like trauma after trauma after trauma rolls in, okay? And it's like a femur fracture, an open fracture, full arrest, a car wreck, a PVA, all this stuff happens like, and you don't get to choose a bullet, or not bullet, a gunshot wound to the chest. Like all this stuff happens, boom, 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 but you got a good team, okay? It was a lot, but it feels okay because you had that good team with you, and I hope that you out there understand that feeling of like, oh my gosh, this is so much. If I did not have these people, I would have been screwed. I hope you've had that. That's a good an example of how stress can be crazy but tolerable. But that same day with a bad team where you don't feel supported and you don't feel like you have anyone to turn to and there's no one to help you and it's just you, you've got the asthmatic, the twin asthmatics that are scoring severe on the score. You don't have anyone to help you get the drugs. You got two of them in the same room. You got three other rooms you're taking care of. And there's no one to help you. How that same stress, it wasn't any more serious than the other stuff I was just talking about, but that day you didn't have any good help. It felt toxic. It felt like it was time to go. Stress can be toxic or tolerable depending on the relationships. It seems self-explanatory, but it's a good point to bring up. All right. Another start point, 90% of brain growth happens before not 5 years old. Okay. Interesting that he added to this, okay? He added the post, there is now, so you've had adverse childhood events since like 1997. So 95 to 97 is when the adverse childhood event study happened. Now they're adding positive childhood experiences to weigh on the other side of a scale. So used to, you would only think about adverse childhood events. You get 1, 2, 3, you got 4 points. Ooh, 4 points. Well, now instead of just having 4 points of bad, now they've put it on a scale, and now you've got stuff that can outweigh on the other side. Did you have a good relationship with your parents? Were your parents married? Did they never get divorced? Did you have a good church life? Stuff that can weigh on the other side. And spirituality is a big deal on this as well. I'll get into that in a minute. But positive childhood experiences can weigh on the other side of the scale of adverse childhood events. Basically saying that what happened back then is not a predictive factor of what's going to happen in the future. We can say on a population level, yes, the more ACEs, adverse childhood events, that you're exposed to, the more likely that XYZ is going to happen, but it's not predictive for a singular person. Interesting that, all right, I'm going to go ahead and talk about the social side. The main guy, Dr. Lloyd, basically said that there's a difference between acute pain and chronic pain. Acute pain, like I just blew out my knee, I got in a car wreck, I had dental surgery. Acute pain is very real. And you shouldn't be afraid to prescribe an opioid for 3 days to cover that 3 days of acute pain. Chronic pain is very different. Chronic pain goes through a psycho, social, spiritual filter of how you view that pain and how you experience that pain. The big thing that they were talking about is pain is not a vital sign. It is a symptom. It is subjective. It is not objective. You cannot call pain a objective vital sign. It is not. Pain being the fifth vital sign is what got us into this whole opioid crisis. That is Purdue Pharma pushing pain meds. All right, we need to move away from that. We need to be able to all agree that pain is subjective. You will not die of pain except for chest pain. It does not. Pain isn't going to kill you, except for chest pain. That's something that, like, the old burnout nurses and medics would say, but it's true. Pain is subjective. It is not objective. We don't have a way to objectively assess pain because there's so many modifiable factors. That being said, your psycho, social, spiritual side of how you look at pain makes a big deal in how you deal with it. So, like, do you have purpose in life? Do you believe in a God? Do you believe in God? The God. And I don't know if you're religious out there, but I am religious. I am a Baptist. I haven't really lived that way in the past, but I'm making it right. But we'll get into that later. We're going to later. Spirituality, how you view yourself in the world of at large, does change how you deal with pain. That's basically what he's saying. So, just so you know, we don't want you to be opioid scared, but we also don't want you to not educate patients, let them have true informed consent, and then not just write prescriptions willy-nilly. So, let's move on to a different guy. This was one of the last people I actually got to listen to. His name is Dr. Jackson, William Clay Jackson. He is also one of the guys from the state. There was two guys there. He's the second guy from the state. They both have been with the state since at least 2010 because they helped write the previous opioid recommendations for the state of Tennessee advanced care recommendations. So he also talked about the biophysical, social, spiritual thing. His like soapbox that he got onto was genes. The genes are either there or not about being predisposed to opioids. However, the amount of stress and like cortisol and adverse childhood events that you're exposed to can activate or not activate certain genes. So how those genes express could be different from kid to kid, even though they have the same parents, depending on their living situation. Meaning and purpose, God affects health outcomes, which I just talked about, we know that. Then he goes into unintended consequences of just unintended consequences. So he was a part of writing those laws, or writing those rules, writing those recommendations. He went into how did we get into this opioid crisis as we know it now. And he started in basically like a play, but 5 stages of the play. The first one, how did opioids even get to where they are now, okay? He called this opioids are useful in palliative care. And Cicely Saunders, this started, I didn't write down a year, but I want to say it was around the 50s. Cicely Saunders is the first woman that said, hey, once these patients get a diagnosis of death, like it's a fatal illness, then they're not well taken care of. They just kind of get written off and thrown away. We need to do something about that. So she went to nursing school. Well, then she went to nursing to the nurses and said, hey, we need to stopping taking care of these deathly ill patients. Then the nurses said, hey, it's not us that are writing them off, it's the doctors. So then she went to the doctors. Then she formed the modern hospice movement. Cicely Saunders, through that whole experience, is the person that formed the modern hospice movement. Now, from that point, she created a hospice care. But what got us to where we are now? Well, in that hospice care, there was a doctor whose mom was sick. And now that they have hospice care, they're taking well care of her. And she was taking oral morphine for some sort of cancer with bony metastasis. And there was no drug to give her right before bed that would last throughout the entire night. The options were you can wake her up in 4 to 6 hours and give her another pill, or you can wake her up in 4 to 6 hours with another shot. But there was nothing that was going to last longer than 4 to 6 hours. So he went to, I forget the guy's name, at Purdue Pharma. They wanted a long-lasting opioid. Not because they wanted to ruin the world or to create a pandemic or an epidemic, however you want to say it, but because they were trying to give better care to this specific type of patients. But this is all about unintended consequences. He created that, Oxycontin, 12-hour opiate. So you can give that to someone, opioid, and it lasts 12 hours. Now, that's awesome. That's awesome. The second stage or part of this play is they went and said, let's make more opioids. Let's make more. This is great. We can do great things with it. So that's what they did. They made more opioids. They were giving them out. They were trying to get them out there. And the way they did it, there was a paper, and it was a letter to the editor in a medical journal. Purdue Pharma basically saw the letter to the editor, stating in the letter that there was like no addiction, it was great for pain, all this nice jazz. And then they quoted it as a study from the medical journal. So anyone can write a letter to the editor. It just happened to be published. They took that letter, then told all the doctors, this is a medical study that shows this XY from this reputable journal. You should give this OxyContin. And how many people do you think went and looked up that study? None. Nobody. Why would you do that? Why would you go look up the study? You don't need to. Then he asked the question, he goes, how do you think we got doctors who are paid very well to put patients at risk? How did we get past the first question of prescribing any medication? Is it safe? Is it safe? That's how they did it, with a letter, okay? Why did we prescribe so many opioids? Do you think, how do we get someone that's paid $300,000 a year to prescribe opioids? It's not going to be with a bribe. What they did was they gave out pens, they gave out papers, they gave out free lunches. And he said that this is because of that psychological factor in your brain that if someone helps you, you want to help them. So if the Purdue Pharma guy came in and brings lunch in for us every Tuesdays and Thursdays, yeah, I'm going to write some more of his scripts for that drug that seems safe. Why not? And that's how they did it. That was the key. That was the key right there. Just giving them free stuff and making it look safe. Because here's the thing. We've known since, even in the play of Shakespeare, when the two main characters go to the shaman or whatever they call it for a sedative, an opium, the shaman says, I don't want to do this because this is not going to be good for you, but because I am poor, I will sell it to you. And I was like, whoa. So we've known about this since opium was discovered, that it's not good. Even in the Civil War, it was known there was a huge opium problem. We've had an issue as a human being species for a long time. It's not a surprise. They just covered it up with fancy advertising and marketing. They did a good job of it. So they made more. The third act to this play is Something is Rotten in Stanford. So he said basically in 2010, the state of Tennessee had this graph, and it shows 3 lines, all going up, all going up. Or I guess I'll do it this way, all going up, all going up, all going up. And what those 3 lines were saying, that as opioid prescriptions were written, more people were having overdoses and more admissions to recovery centers were happening. And we all know, correlation is not causation. But everyone in that room went, you know what? We should write less prescriptions. If we write less prescriptions, less of this is going to happen. That's what they did. And what they did was they tried to write it in a way that... There's a bird. What are you doing, bird? Okay. They tried to write it in a way that was like a smart bomb, where they can target the issue. And this is where... Come on, man. Well, they can target the issue. And this is where unintended consequences happen, because they wrote these laws and rules to try to target the bad apples out there that were pill milling, just giving out opiates all the time. But what they saw was a reduction in opioid prescriptions across the board. So they wrote these rules and regulations as to try to target the bad apples and the bad actors What ended up happening was the oncologist wrote 20% less. The ER physicians wrote 20% less. The, I don't know, name another specialty, wrote 20% less opioid prescriptions. So they wrote smart laws, but everyone, we're kind of scared. So now these laws that they've written, or it makes it harder to get opioids. And now this guy's an oncologist, so this is affecting his patients more than anybody else. His patients can't get their scripts. They have to go sometimes to multiple pharmacies. Walmart and Walgreens aren't carrying opioids right now because they're in a big law. They're included in that Purdue Pharma lawsuit. So his whole thing was the unintended consequences. You'll never be able to see it. You'll never be able to see it. They haven't seen a reduction in the deaths from opioids. In 2010, it was 1,000. Now, of this past year, it was 3,000 deaths in the state of Tennessee due to opioid overdoses. And the thing that they couldn't see coming, the thing that happened around 2015, was fentanyl started getting shipped in from China to the public. Because we had fentanyl in the ambulance, but like mass-produced fentanyl, which started being shipped in. So we don't really have a heroin issue anymore, according to them. We have a fentanyl issue. Fentanyl. It's 40 times stronger than heroin, because heroin's four times less strong as morphine. Fentanyl's 10 times stronger, so it's 40 times stronger than heroin. And no one saw it. No one saw it coming. Fentanyl's in everything. And they're making pills that just look like hydrocodones with fentanyl in it because it's cheaper and easier. They're adding other things in there to make the high last longer. So they didn't see it coming. And that's kind of the state we're in. They're sitting there going, well, what do we do now? How do we help? And the big takeaways were harm reduction, and I don't really like harm reduction because it's just where I live. It's got a negative connotation. But the point that he made, and when I say harm reduction, like needle exchange programs where you reduce HIV and other bloodborne illnesses, Narcan, where you say, give someone Narcan over and over again, save their life. And just because it'll work. The ER isn't really conducive for having sympathy or empathy for those kinds of patients. But basically, if you look at it as someone that has this addiction where it's 10 times the strength of wanting food and water, what would I do for food and water? Eventually, I'm going to kill for food and water. 100%. If I feel 10 times strongly as that, what am I going to do? And that's kind of what these addicts, or I don't know what you say nicely, to be honest with you. These people that are addicted to opioids feel. You put that position. That it's a physiological feeling, right? It's not them just wanting, it's the need. You can't take someone's food away. So then you look at it that way. Then the other takeaway is that people that actually recover from an opioid addiction are kind of like a turtle on a fence post. If you look at a turtle on a fence post, what do you already know about that turtle on a fence post? You know one thing for sure, they didn't get up there on their own. There ain't no way that turtle climbed up the fence post. Someone helped them get up there. And that's what recovery is. The guy, Dr. Lloyd, that ran everything, his rehab was 95 days. He goes, nobody gets that. Nobody gets that unless you're a doctor, a pilot, or an athlete. But that's what people need. Those first 100 days are so key to getting that brain regenerated. You need to help these patients. And helping these patients by making them quit cold turkey is unrealistic. They need some sort of medication to help get over the gap. And they went into depth on that. And I'm going to be quite honest with you. It kind of went over my head about the different choices of medication and which ones that work better in different situations. What I'm going to say is I like how they said it. That they need the medication because it's a physiological dependence. So that I don't look at it as drug-seeking behavior. These MFers are never going to get off this med. It just kind of opened my eyes up to what it is and how dangerous it is. Because then, someone asked the question, like, should we even have opioids? Well, one of the guys stood up and goes, well, let me ask you this. Do you think we as a species want to not live without opioids? Because it's the only big pain reliever we have to knock out, like, certain kinds of pain. So, like, if I get in a car wreck and break my femur, I want opioids. It's not something I want to go without. I don't think we're ready for that. I want my cancer patients to have opioids. There is a place for it, but it comes with a lot of risk. There's a lot of risk. The last thing I'm going to say about the meds, the methadone, the other two that he said, I can't remember right now. The meds to help fight addiction have a 70% reduced in mortality rate. That's crazy. An AED on the wall has a 30% reduction in mortality rate. It's kind of hard to look at those numbers and go, man, why do we have an AED and not be willing to give some sort of medication to help fight these cravings? Why do we have an AED and not treat these patients adequately? It was very informative. It was very eye-opening to be cautious with your prescriptions, educate your patients, and then when you come across someone that has a true addiction, look for it to get them the care that they need appropriately. It was awesome. All right, that's really it, guys. I had that conference. I'm glad I got to talk about it. I'm glad I got to jump on here with y'all. I'm going to be doing a sensitive skills day exam, which I've looked into, and it means just, some pelvics, some prostates. Gross. Other than that, things are going well. Spring break's coming up quick. It's coming up quick. We're going to the mountains. So, one of these videos is going to be us in the mountains. I'm not doing Nurse Practitioner Update, but we're going to play in the mountains, and I'm going to take some video of us fishing or something. It's going to be awesome. Guys, as always, remember, like, subscribe, share with a friend, and always keep your corn on the cob.